Well, thank you, and thank you for that extraordinary series of questions. I'm sure I won't be able to answer them all, but let me try and at least answer some. Okay, I think it's important to emphasize again how good CT scans are. And this is a short list of ways that CT has revolutionized medical practice, and I won't go through it, but you all know these things, and there are many more too. So again, everything we say we have to look at through the glasses of CT is a wonderful tool. So why the particular interest in CT? Well, it's really the doses, and because the doses in general are higher than they are for conventional planar examinations, and that's just the physics of how CTs work. And you see on the, let's see, yes, there's the little green fellow. Yeah, you see on the top here, conventional CT, conventional exams, and here's CT on the bottom, and PET CT and also. And you see a significant difference in organ doses. And let me emphasize here on in, I'm always going to be talking about organ doses. I'm never going to be talking about effective doses, because I think it's a rather flawed concept to try and average the dose over different parts of the body. You should, if you're going to estimate risks, you should know the organ doses. So this was actually alluded to in the last talk, but I mean, the other reason we're interested in CT is because it's increased so rapidly over the years. And it increased very steadily up to about 2010, 2011. And since then, interestingly enough, it's flattened out or maybe even decreased for reasons that, of course, we don't really know. Is it to do with issues of risk? Is it merely to do with the economics of healthcare, or is it a combination of them both? So I'm going to be talking about risk and radiation risk. So we need to know what doses, roughly, what we're going to be talking about. So as everybody in this room knows, there's an enormous amount of variability in different types of CT scans and different individuals. And many different things that come into play to estimate an organ dose. But so I think very roughly we'll say that the ballpark that we're interested in is the 5 to 100 millisievert organ dose range for a single series of scans. So we're interested in what are the risks associated with those sorts of doses. And there are two ways, basically, that you can go about trying to answer this question. You can either go to the gold standard, which is AAPM survivor data, estimate organ doses from CT and put the two together to come up with risks, or, in an ideal world, direct epidemiology on people who received CT scans. So I'll talk about both of those, so let me talk about this one. Oh, right, color change. Yeah. So atomic bomb survivors. So they are undoubtedly our gold standard, and the main reason is that the numbers are large, and the follow-up time is very large, and it's entire populations that's exposed: men, women, children. So in this picture of Hiroshima, what you see is every dot of a different color corresponds to one individual exposed to a different dose. So the brown dots actually are individuals exposed between 5 and 100 milligray. So this is the range that we're interested in. And there are about 25,000 of those individuals, survivors at Hiroshima and Nagasaki. So we do have some data at the doses that we're interested in. And there are, of course, there have been many studies over the years of actually focusing on the low-dose population. And here we have cancer mortality and cancer incidence, where this is Dale Preston's work, where he's looked for low-dose trends. So in other words, he's asking the question, at what dose range can you actually see a significant trend. And for cancer mortality, it's about in the 0 to 0.1 gray range. And for cancer incidence, it's in the 0 to 0.15 gray range. So based on AAPM survivor data, there is clear evidence that in the dose range that we're interested in for CT scans, there are risks associated with those doses. So no, it's not an extrapolation from some high-dose data to low-dose data. It is actually looking directly at low-dose data. So back in 2000, oh gosh, it's all those years ago, 2001, Eric Hall and some colleagues and myself put together some risk estimates in which we estimated organ doses for CT usage at the time and then applied AAPM survivor risk estimates. Again, there was no major extrapolation going on here because we are in the same dose range as these low-dose AAPM survivors. And the paper would have gone completely unnoticed, I'm sure, except that it got taken up by USA Today in 2001 and hit above the fold in USA Today. And I think this actually, much more than our paper, started to create some sort of momentum. And I think this meeting today, in some sense, is a result of that USA Today meeting. USA Today publication. So that was the first way, that certainly was the only way we had at the time to estimate risks from CT, was to estimate doses, estimate risk per unit dose from the AAPM survivors and put the two together. This did stimulate people to think about, well, can't we do direct epidemiology on people who received CT scans? Then we don't have to go to the indirect route of doses and risk estimates from Hiroshima and Nagasaki. We actually tried very hard to see whether such a study could be done in the US, and eventually concluded it was not feasible. There are too many factors against us in the US. On the other hand, in Britain, which was ironic because CT rates in the UK are order of magnitude less than they are in this country, because they have a national health service, they were able to essentially get pretty well every child who'd ever had a CT scan and link them into their epidemiological databases. So in 2012, so a decade or so after that first risk estimate, this paper got published in The Lancet, about a 10-year follow-up of 175,000 children who received CT scans between 1985 and 2002. And here's the results from those studies. They looked at leukemia and they looked at brain tumors, and they estimated individualized doses for each. So there was a pretty clear and statistically significant dose-response curve for both. Oh, right, yeah, indeed it was. Yeah, well, exactly. And that was followed up a year later by a moderately similar study from Australia. The methodology was actually quite a lot different. And arguably a little bit of a weaker study, although the numbers were larger. There are various issues, one of which is they didn't actually estimate doses. They estimated simply, or they had used a number of CT scans per individual. But they certainly did see a dose-response curve for all cancers combined. So let me talk for a couple of minutes about what I see as the potential weaknesses of those sorts of studies, the potential biases that there might be. And there's really two, and they have different names, and to an extent these are my names. Reverse causation. So in reverse causation, a CT scan is ordered which turns out to be due to the symptoms of a cancer, but the cancer hadn't at the time been detected. but ended up being detected sometime later. So it might appear then that the radiation from the CT scan caused the cancer, but actually it didn't. The cancer was already there, and that's what the CT scan was ordered for, but it wasn't known at the time. So that's reverse causation. And the other I call confounding by indication, and that's when a CT scan is ordered for some condition, an example is Crohn's disease, and that condition itself causes an increase in cancer risk. So again, it's not actually the radiation that's producing an increase in cancer risk. It's the condition for which the CT scan was ordered. So both of these are potential biases and potentially could explain the dose responses that were seen in both the UK and the Australian studies. Now, the reverse causation, I think you can assess pretty well by simply taking a longer and longer lag time between the time of the exposure and when the cancer was actually diagnosed. Because if the cancer was really there at the time of the CT scan, well, you should expect to see it in the next year or two. So if you took a longer and longer time between time of exposure and CT scan diagnosis, the effect should go away completely if it really was an artifact of reverse causation. And actually, in the Australian study, they did look at increasing the lag time between exposure and the CT scan being actually assessed. I'm sorry, between the CT scan and the cancer being diagnosed. And even when they went to pretty long times, lag times, they still saw a dose-response relationship. So I don't think this effect could be a dominant one, this reverse causation. And the other effect is potential confounding, where in fact it's not the CT which is causing the cancer, it's the reason for the CT that's causing the cancer, like Crohn's disease or some other disease. And that we can actually assess quite well by, if you can go back into the records and figure out, well, why was every single CT scan actually done? What was the reason for that? You can actually look at this confounding effect. So back at Columbia Medical Center, we've gone back to the files and tried to relate every CT scan in a period from 1994 to 2013 with the actual reason for that CT scan. So we found 70,000 patients, 200,000 CTs. And again, we tried to eliminate the possibility of a cancer already being there at the time of the CT. So then we classified the reasons for the CT into lots of broad categories. So what we end up with is hazard ratios for patients who have a CT scan for a given reason relative to patients who had a CT scan for any reason. And so we should be able to see any major effects this way. So what you're seeing here, this is abdominopelvic CTs and colon cancer, which is stratified by the different reasons why that CT was given. Is it some problem with the kidneys? Is it some lesions? Is it trauma, heart, lung, and so on and so forth? And what you see is, this is one, so no effect at all here. So what you see is they're actually pretty uniformly around one, so a few are a bit less than one, or a few are a bit greater than one. So no real evidence for any systematic bias here. And you can actually calculate what the bias is for any of these particular individual events, and they're pretty small, they're a few percent. So at least based on what we've done so far, and this work is actually still ongoing, so preliminary, we don't see that there are any major biases to do with the fact that you're actually diagnosing particular diseases which themselves are related to cancer. So the other thing you would like to do to see if what we're doing makes sense is to ask, well, the direct risk estimates from epidemiology, are they consistent with the old risk estimates which were based on AAPM survivor data? So basically, the British group estimate an absolute risk of about 1 in 10,000 per head CT scan, both for leukemia and for brain tumors. So how does that compare with what you would get from ABOM survivor data? Well, you have to correct for the ABOM, the epidemiology for a lifetime follow-up, because the average follow-up in the UK CT study was only about 10 years. And of course, cancers can appear much later than that. So these are the 1 in 10,000 numbers corrected for lifetime follow-up here and compared with the ABOM based estimates. And you see they're definitely in the right ballpark. Not exactly the same, but they're within factors of 2, which in this world is pretty good agreement. So I think the ABOM-based risk estimates in the end have turned out to be quite consistent with the direct epidemiology which followed it. So, my view, these pediatric CT epidemiological studies are pretty important events in our field, because I don't think we can say anymore that these CT risks are too low to be detectable and may not actually even exist. I mean, we have direct epidemiological data to suggest that they do. So this is actually a quote from the AAPM website, which you can see today. The other thing the AAPM mentioned, which was actually one of the questions that was posed at the beginning of this talk, could it be that actually having numerical quantitative risk estimates, and I'm quoting from the AAPM here, causes some patients to refuse medical imaging and placing them at substantial risk? So there have been actually 3 publications which really address this issue. One just a couple of years back, where a whole series of patients in the emergency department, or the parents of children, I should say, in the emergency department with head injuries, were given appropriate radiation risk information. And no parent subsequently refused a CT scan. Back in 2007, slightly differently designed study, Larson looked at 100 parents of children who were recommended for CT, and they were given, again, appropriate estimates of what the risks might be. And again, nobody refused a CT scan. And more recently, actually, not in the CT context, but in the similar context of fluoroscopy, 120 parents of children recommended for fluoroscopy were again given a pamphlet with radiation risk information. And again, 0 refused the recommended fluoroscopy exam. So at least from the literature, there's no evidence that patients or parents of patients are actually refusing medical imaging when they're told about the very small risks associated with the radiation exposure. So that was all to do with the parents of children, and in fact, all those epidemiological studies that I talked about were all pediatric CT. Now, is that actually right? Should we actually be concerned about children and young adults relative to the grown-up population? I'm not sure it is, and the reason I say that is, so this is the age distribution of CT scans in this country, and of course CT scans for children is a comparatively unusual event, whereas a CT scan in a 40 or 50-year-old is a much more common event. So it is true that children are more sensitive than adults to radiation exposure, but does that compensate for this very big difference here? I think it possibly does not, and so I think we are probably doing a little disservice if we focus entirely on the pediatric CTs. We should be looking at adult CTs. And we actually published a paper just a couple of years ago designing an epidemiological study quite similar to the ones that I described before for children, for adults. So it really can be done in an adult population. Yeah, won't go into details, but it is feasible. So let me conclude as lights have gone on here. So the first question that I think I was asked to address was, are individual CT radiation risks real? And I think the answer is almost certainly. The AAPM-based data is based on doses corresponding to the doses from CT scans, but now we have direct epidemiological evidence, and it doesn't appear that the biases of those studies are going to be significant. That said, it's unquestionably true that the risks are small. And if the individual risks are small, I think this must be true, that whenever a CT scan is clinically warranted, the benefit will far outweigh any possible individual risks. And that would be true if it's an individual's first scan, or if it's that individual's 100th CT scan. If the CT scan is clinically warranted, they should have that CT scan. But of course, it goes without saying that, particularly to people in this audience, we can and should continue to lower the dose per scan. But the final conclusion, I think, is that if the risks are real, then we really need to be thinking more about reducing clinically unwarranted CT scans. And again, you heard more about this in the talk before. So the concern here is about the population exposure from the roughly 1/4, maybe it's a third, who knows, of CT scans that may not be clinically warranted. So if we assume there are something like 80 million CT scans per year in this country, then perhaps 20 million or 25 million CT scans per year in this country may not be clinically warranted. And if indeed there is a small individual risk associated with those CT scans, we really need to focus on this issue. And there I will stop. I see my time is exactly up.